Hello and welcome to Chapter 8. This chapter is focused on skin disorders. This is just our A&P review of the functions of the skin. We do have several. One of the functions is that it is our first line of defense, and as we've learned over our previous chapters, the first line of defense is just that natural barrier that we have against pathogens and things that are harmful to us. Secondly, it does serve as a way to prevent excessive fluid loss. We do perspire through our skin, but it also helps to hold in moisture that we don't need to lose. So the skin is really effective at doing that. With allowing us to perspire, one of the things that it does is that it helps to control body temperature. Again, you can do that through perspiration or the evaporation of sweat, secretions, and also vasodilation through our vessels that run through the skin. The skin is also necessary for sensory perception. It helps us feel different things, temperatures, hot, cold, when things have different textures. All of that would help us sense our outside environment, help us process that through our brains. And then we have that it synthesizes vitamin D, and particularly when it's exposed to ultraviolet light. So these different functions of the skin is what makes it very, very important to us to make sure that we maintain its integrity. Again, you can have issues when individuals have breakdown in the skin. Of course, you can introduce infection, and some of the things that we'll go over would be disorders and impairments from our skin. It's important to note that we do have mixed flora or different organisms that live on the body, particularly our skin. We do have residue or microbes that can reside under the fingernails, hair follicles, and even in our glands, particularly those sebaceous glands. So it's important to know that we can get those opportunistic infections because if the skin is broken, that flora is now getting into our system, particularly the circulatory system. And if they're not supposed to dwell there, they can proliferate or multiply and cause infections. So it's important to make sure again that the skin remains intact due to those opportunistic infections. And again, sometimes you can have systemic spread, and yes, you can see sepsis as a result of broken skin. So normal flora should not be harmful under normal circumstances, but if it is presented in a way where there is broken skin, it can potentially be harmful. So the first thing we'll talk about is skin lesions, and this is not necessarily disorder, but just the issue that can occur with our skin, right? You can have skin lesions for various reasons. You can have different causes such as sickle cell anemia, liver disease. Even certain infections can cause skin lesions, such as chickenpox, and that's where you have those itchy openings in the skin, right? Allergies to drugs, allergies to food, or any allergen can produce skin lesions, and you could be exposed to toxins such as those in your workplace. So when we talk about skin lesions, these are areas of skin that ends up being different from the surrounding skin. So you can see different colors. It can be slightly raised. You can have lesions that are open. It looks a little bit different from the rest of your body. When you talk about skin lesions, it does depend on the location and how long those lesions have been present. Sometimes these lesions can open and close, or you can have exacerbations or remissions of your skin lesions. And again, it does depend on the color, texture, and even what's coming out of it or the drainage. And we do look at elevations or raised areas on the skin. If you do have itching, for the duration of this lecture, I may refer to itching as pruritus. That is another medical term for itching. And when we talk about pruritus, these are normally associated with allergic responses or even chemical irritation. It can be caused by infestations, even by insect bites. You can get pruritus. So this is just a generalized term for itching. When we think about itching, though, this mechanism is not always understood. We think that when we release histamine as a part of our inflammatory and hypersensitivity type 1 response, it does cause marked pruritus or excessive itching. But again, you can get it from scratching, you can get it from breaking that skin barrier, but we don't necessarily understand the mechanism by which pruritus happens. Just know that if you do see this term, you look at it as itching. So here you have different types of skin lesions. This table is really excellent because it tells you the different types of lesions. You have macules, papules, nodules, pustules. You may even have had a diagnosis with some of these, right? So I would take some time and familiarize myself with the description of some of these skin lesions. The ones I would pay very close attention to would be nodules or the palpable elevated lesions. Of course, they vary in size. The crust, where you have a dry, rough surface where there's old exudate or dried exudate or blood. Keloid, which is a raised irregular mass of collagen, and normally that is resultant from scar tissue. Ulcer, where you have loss of tissue in the epidermis and the dermis, where you have bleeding, there's an opening, and sometimes ulcerations do come with an odor or are associated with an odor depending on how bad it is. Um, the other ones that I want you to pay attention to is a comedone, and this is where you have a mass of cerebrum or keratin, and it technically blocks the hair follicles specifically. So you may not see hair growing in that area because there is literally a layer blocking the hair from coming out. So again, I'll repeat, please make sure you pay attention to nodules, crusts, keloids, ulcerations, comedones, but just go ahead and familiarize yourself with most of these terms as you may see them again in later courses. And here are some pictures of those lesions that we talked about on the previous slide. Again, you have the ulceration, you have the nodules, but this is a really good illustration. So again, do take some time to just look at the different illustrations and associate it with the definitions, and it will allow you to see how these different areas vary on the skin. So because we have so many varieties of skin lesions, as you saw on the previous slides, it's important to narrow down the causes of these skin lesions. Again, allergens can cause this, infections can cause this. We can even have skin lesions secondary to another disease process. So if we do have these skin lesions, especially if they have exudate, what we'll do is called culturing that lesion or culturing that wound. And what that does is that it helps us determine what exactly is causing that wound. So it could be a fungal infection or a parasite that's causing the wound. It could be a bacterial infection, and the main organism is a bacterium. So what we'll do is culture it, and we may even do something called a sensitivity test. And this sensitivity test will allow us to determine what types of drugs are most effective against this type of microorganisms. So again, culturing and staining of specimens are important. We may even biopsy, and please remember when we talk about biopsies, this is where we're taking living tissue from that area and we're detecting malignant changes. So these biopsies are really important because it does help us determine the type of skin cancers, and we may even do this prior to or following the removal of a skin lesion just to make sure that we've gotten rid of all of it if there was treatment involved. So biopsies are for living tissue, but we're just trying to detect if there's some sort of malignant changes. Of course, we can do blood tests, especially if we know that skin lesions could potentially be caused by an allergen. We could see if there's some sort of blood association with it. You may have an abnormal immune reaction. So pulling your blood tests or specific titers will allow us to know if you're more susceptible to developing certain lesions or not. And then you may even do skin testing where you use the scratch method. We use this method a lot when we talk about allergies as well, because if you have the part of the body, normally we do it on the back, they'll have different samples of allergens and they'll just scratch that one particular area of the back. And if you have some sort of reaction, whether it's mild or heavily violent, where you go into anaphylaxis, we would be able to know that's what's causing your skin lesions. So again, when we talk about this, this could be any of the skin lesions, papules, macules, nodules, comedones, any of these can go through these sorts of testings. That way that we can determine how to best determine your course of treatment. As I've mentioned before, you do have different terms for your skin lesions, but let's talk a little bit about the treatment. If you're having itching or pruritus, normally we'll use some sort of topical agent to help reduce the sensation, or we may use antihistamines or glucocorticoids to help reduce that inflammatory response. Again, histamine is a inflammatory biomarker, so if you use an antihistamine, it is literally blocking that inflammatory biomarker, which will ultimately help us reduce that inflammatory response. Of course, we want to encourage avoiding allergens because most likely if we're having skin lesions due to certain causes, it helps reduce the risk of recurrence of those skin lesions again. If you do have an infection, of course, you can use antibiotics for bacterial infection, but I do want to make a note here that antimicrobial therapy would be a better term here, because if it is a parasite or a protozoa, or even a fungal issue, you would have to use a medication that's specific to that type of organism. And if it is a precancerous lesion, it's not necessarily malignant yet, or if it's mildly or it has not progressed, they may use laser therapy, surgery. They may try to get rid of that part of the skin that is affected. That way we don't have it spread to different parts of the body. Let's move into skin inflammatory disorders. So the first one we'll talk about is contact or allergic dermatitis, and this is simply a rash on the skin. It involves the epidermal layers, and normally this is caused by allergens. This can be soap, this can be plants, chemicals, toxins, cosmetics, even metals can cause a rash on the skin. Sometimes you have a pruritic rash. You can have rashes that are not itchy, but then you have rashes that are itchy. If it is itchy, we call that a pruritic rash, and it develops on the site shortly after exposure. If it is direct chemical or mechanical irritation, it doesn't necessarily involve the immune system. But if it does have this response, we still consider it inflammatory due to direct exposure. Um, Pathophysiology: with the first exposure, you do have a mild reaction, but subsequent exposures, you will have more aggressive reactions, so that rash may become bigger and wider and more large and even more itchier, and it could become inflamed. Um, so if it is in a specific location, sometimes the contact dermatitis is in one area of the body and it does not spread. It can give you a clue as to what actually caused the contact dermatitis in the first place. Again, you have signs and symptoms: erythematous area, which is redness; edematous area, you do have some swelling. You may even have small vesicles there, and it is itchy. Normally, the treatment involves removing the irritant and using topical glucocorticosteroids. The next one we'll talk about is urticaria, and this one is where you have generalized hives on the skin. Of course, this affects the upper layer of the skin, the epidermal layer, and this one also can be caused by different allergens, and these would be the same allergens as before. I just listed a few here: drugs, fruits, vegetables, shellfish. Anything that can cause a reaction, an allergic reaction, you do have the possibility of developing hives. It is the result of hypersensitivity reaction type 1, so it is mediated by immunoglobulin IgE. Remember, that is an antibody, IgE as an egg. And the signs and symptoms: of course, you're going to have itchiness, or the lesions are going to be highly pruritic. They will be red. Of course, they're going to be raised, and they will be hard. As far as treatment, you have several modes of treatment. Of course, you want to use antihistamines. Histamine is that inflammatory player. And what you can do is what you can do is use an antihistamine to help reduce that inflammatory and allergic response. Corticosteroids also help reduce inflammation. And the one that they have here specifically, omalizumab, you may have seen this called Xolair. This is a medication that specifically reduces the amount of IgE circulating in the body, especially during an allergic attack, and it also helps to reduce inflammation as a result. Next, we have atopic dermatitis. This is also known as eczema. If you've had eczema or have experienced eczema before, this is something that you are actually born with, and it's a very itchy and uncomfortable disease. It's atopic, which means that it's inherited in tendency. It does affect those upper layers of the skin, the epidermal layers, and like I said, the etiology means that it is inherited, so you are born with this, and normally it develops in early childhood. We would know that you have it. So you do have chronic inflammation, and really what's happening is that it is a response to allergens. Sometimes you can get an eczema exacerbation due to temperature changes. You can even get eczema exacerbation from stress. So a lot of things can increase the way that eczema is exacerbated. So it is something that can come and it can go. It may not be as strong at one point, whereas other times it is extremely uncomfortable and unbearable. Um, so when we talk about why it happens, it's because you do have increased levels of IgE. Again, IgE is that immunoglobulin or antibody that is associated with hypersensitivity reactions, specifically type 1. So you do have an over response of inflammation, an over response of that part of your immune system. So what happens is that you do tend to have these exacerbations and remissions depending on the level or your blood levels of IgE. There are different complications that can result from atopic dermatitis or eczema, but one of the main ones that I want to talk about is infection. That's reasonably so, right? When you're scratching and you're incredibly uncomfortable, you are literally making openings in your skin, and we still have normal flora regardless of if our bodies was born with eczema or not. So those that have eczema still has normal flora, and those bacteria or maybe even fungal um, microbes can still get into those openings and cause infection. So a lot of the times these individuals will still need to be treated with antibiotics if they suddenly come down with an infection. You do have different signs and symptoms. So with children and infants, normally you do have a red rash. You may have that watery serous exudate on the face, chest, and shoulders. Anywhere where that rash is, you will see some serous exudate. When you have adults that suffer with eczema, the rash is normally pruritic, and normally they're on the bending surfaces or those flexor surfaces. The rash is normally dry, scaly, but again, in both instances, it is a very uncomfortable rash. As far as treatment, you want to eliminate things that are causing it. So if it's soaps or different fabrics, you may have to make sure your temperatures are set to a certain level, and maybe even decrease stress. Eliminate the aggravating agent. You may see these individuals use topical glucocorticosteroids and also, of course, antihistamines. The next one we'll talk about is psoriasis, and this one's a little bit different in that it does affect two layers of the skin. You still have a chronic inflammatory disorder. We do believe that it is genetic and inherited through family. But with psoriasis, it does affect the epidermal layers, and now it goes a little bit deeper, and you have those dermal layers that are affected. It is something that normally onsets in your teenage years, and we do see remissions and exacerbations and even differences in the severity of the psoriasis. It can be on the arms. You can see this on scalps. You can see this in different areas of the body. What happens is that you do have excessive proliferation of your keratinocytes, and these are cells that help to produce skin. And when you have proliferation or growing of these types of cells, it does lead to the thickening of your dermal layers and even your epidermis. And yes, you can shed all of these even in one day. So even with people that have psoriasis in the scalp, you'll notice that they have a lot of flakiness there. The reason why is because their epidermal layers are reproducing at a very quick rate, and that causes the shedding. So the picture that's located on the left here, you'll see that their patches, they are a little bit raised, but it's mostly dry, and you do have like white to silver scales that are located on those patches. But even with the top picture, you do see like more redness to those scales, but most times they do have this scaling over them. You do feel sore, you do feel itching, and yes, they do bleed because of that thickening of the skin. And another effect that you may see with these individuals is that you'll see rugged nails or pitted nails, and the joints are stiff. We treat this with glucocorticosteroids, and you also have medications called methotrexate. You may recognize this medication for cancers. We normally use this medication to treat cancer of bones, lungs, and blood, but it also can be used to treat rheumatoid arthritis as well as psoriasis. So when we talk about this medication, it is multimodal. As far as tar preparations, this is something that they would put directly on the skin, and it's actually really nice because what happens is with the tar, it helps to cover those areas, and the tar is cold tar, and it'll cover those areas, and it helps to relieve the soreness, it helps to relieve that redness, itchiness, and it also helps to reduce the scaling effects of the psoriasis. So it's actually a really nice addition with multimodal treatment with the glucocorticosteroids and your methotrexate. Next, we'll talk about pemphigus, and you do have two different types listed here. You have pemphigus vulgaris, and then you have pemphigus foliaceus. Pemphigus vulgaris specifically affects the mouth, whereas pemphigus foliaceus affects other areas of the skin. This is considered an autoimmune disorder where the body is attacking itself. You do have the development of autoantibodies that disrupt your epidermal cells, which causes bullae or blisters to form. Um, Ultimately, you do have the shedding of those blisters and that skin, and it leaves that area open, and it leaves it very painful. And as we know, if you have open skin, you can get a secondary infection. If you have a life-threatening or extensive issue with pemphigus, you can develop something called Stevens-Johnson syndrome. And what that syndrome is that it is a rare disorder of the skin and your mucous membranes, and it's normally a medical emergency. And you can get this as a just as a complication of pemphigus, or it can be due to other issues like drugs or something that you took. But either way, Stevens-Johnson syndrome is a life-threatening emergency, but the treatment is to hopefully remove the cause, hopefully stop things that would cause you to get exacerbations. As I've stated, your signs and symptoms, you can have it in the mouth and the skin. You do have blisters that are painful, but they do not itch. That is one key factor here, non-itchy skin. But with Stevens-Johnson syndrome, if it develops secondary to this pemphigus, you do see some swelling in the mouth and in the throat. You want to treat this with immunosuppressants and glucocorticosteroids. The next disease that we'll talk about is called scleroderma. This is also known as Crest syndrome, and we actually don't know why it happens, but we do know it mostly affects women, and sometimes it shows itself between the ages of 35, 45 to 50. So when it comes to this disease, it can be systemic, and it can occur in any area. It does affect the epidermal layers. As far as the pathophysiology, you do have increased collagen, which ultimately causes more inflammation and fibrosis within your skin. What happens is that because of this increased collagen deposition, you do have the tightening of the skin. Um, so what you'll see with these individuals is that you'll have intestinal obstructions. You could have respiratory failure caused by tissue distortion, especially in the throat, and it can cause renal failure. As far as your signs and symptoms, as I've mentioned, it does cause you to have immovable areas of the skin. It is very tight in those areas. It is hard and shiny. Normally, your fingertips are now narrowed as a result, and you do have Raynaud's phenomenon where you have an issue with your capillaries um, at the fingertips. Your facial expression is normally lost due to this tightening of the skin, so you can't smile or frown. You do have movement of the mouth and eyes that's impaired. Again, because your circulation is essentially cut off due to the tightness, you may have various organs that are affected, specifically your kidneys, but you can also have your intestines affected and also respiratory failure because your lungs are then affected as well. As far as treatment, it does depend on how you present. Again, not everybody presents the same way with scleroderma, but common treatment modalities is immunosuppressant therapy. You may have to use vasodilators, and this is particularly with that Raynaud's phenomenon to help loosen those capillaries. And then you have corticosteroids and NSAIDs. Next one we'll talk about is more so of a hand deformity. This one's called Dupuytren's contracture, and again, it's just like what it says. It does cause a contracture in your hand. It does affect one finger, or it can affect more fingers depending on the extent of the contracture. But what's happening is that you do have knots of tissue that are formed under the palms of the skin, and eventually it is pulled so tight that you have a bent position from the hand. Of course, the signs and symptoms is an obvious contracture in the palm of the hand. And as far as treatment modalities, you have stretching, you have enzyme injections, radiation treatment. Sometimes you may even have to have a splint or even surgery. And when we talk about surgeries, that would be a fascistectomy, or the cutting of that fascia to help release that contracture. So it just depends on the course and how severe it is before they opt for these different modalities. They may even prescribe steroid therapy to help reduce that inflammation in those areas. Why do we get it? We actually do not know. So the etiology is idiopathic. We're switching gears here and we'll move into bacterial skin infections. And it's important to note that you have infections that could be caused by viruses, fungi, other types of microbes, even parasites, bacteria. Most times, if we have a skin infection, it's caused by opportunistic microbes that are not normally harmful, but once they get into the body through a cut or a abrasion, that's where you see a serious infection develop. And it also depends on the immunity of that individual. So if they are not able to fight off said infection and their skin is open, they have a multimodal reason as to why they would develop an infection. The other thing I want to mention to you before we move on is that you do have primary bacterial infections versus secondary bacterial infections. When we have primary bacterial infections, this is caused by your resident flora, whereas secondary bacterial infections, these are ones that develop in your pruritic lesions, open lesions, and even your wounds. So the first one we'll talk about is called a furuncle or a boil. And this is where you normally have a pocket of tissue that is red and it's firm. It's a nodule, and it normally turns into an abscess that has drainage that's purulent or has purulent exudate. You can have all kinds of causative organisms, but the one that we will stress here is Staphylococcus aureus. And normally you have skin normally at the hair follicles that are most affected, but you can get these on the face, neck, and back, especially if there's hair there. Um, so it normally spreads inside of the dermis, so it doesn't affect the epidermal layers. It goes down into that dermal layer. And as far as your signs and symptoms, of course, it'll be red and inflamed. It'll be angry. You'll have that abscess with the purulent drainage. Of course, it can have an odor, and that nodule is painful because it's pushing on those nerve endings. As far as the treatment, of course, we'll use NSAIDs. analgesia such as ibuprofen. You can also use acetaminophen. It's not an NSAID, but it is an analgesic. You also want to use warm compresses on boils, not cold compresses, because that will worsen the pain. Warm compresses work best on these boils. You may want to drain, so you may have to lance it. And as a note, when we lance, we want to do that under medical provider, because of course that would be a form of opening the skin, and you don't want to accidentally introduce more infection in an already infectious area. And also note that we can use antimicrobial therapy, and particularly if it's Staphylococcus aureus, that is a bacterium, so we would use bacteria, antibacterials. Next, we have impetigo, and as you can see on this photo, you see somewhat rashes over the mouth. Most times, impetigo affects children, infants, young babies, and it is contagious, especially through contact. Normally, the organism that causes this is Streptococcus aureus, and if it's not treated, it can lead to kidney damage or glomerulonephritis. Signs and symptoms, of course, you're going to have some lesions on the face, specifically red vesicles. Eventually, these vesicles rupture and they turn a brown or yellow crust color. And if you look up underneath, there is a honey colored liquid, and they are very itchy. Again, so impetigo is more so based on the causative organism, again, that Staphylococcus aureus, and of course it's on the skin. Normally, the way you treat this is through antibiotics, because Staphylococcus aureus is a bacterium. So the best way to treat it is through antibiotics, and they may even have a topical version of that to go directly on the skin. You may have heard of flesh-eating disease before, or necrotizing fasciitis. And if you've heard the horror stories about necrotizing fasciitis, it is a very, very rapid and very, very aggressive form of a skin disease. It does involve where you have tissue invasion through different organisms. The one we'll talk about is Staphylococcus pyogenes, but either way, this can be very devastating because of the effects of the skin. So what happens with necrotizing fasciitis is that you do end up with a decreased blood supply to the tissues. And when that blood supply decreases to the tissues, you end up having destruction to the tissues. There is an enzyme called protease enzyme. This destroys the tissues, but also the tissues are destroyed due to the lack of oxygenation. As we know, decreased blood supply to tissues means that we're not getting oxygenated. So there is a layer of necrosis as well. As I've mentioned, you do have Staphylococcus pyogenes that is the main organism. And oftentimes when it develops, it's from a small trauma or cut in the subcutaneous tissue, and eventually it spreads to skeletal muscle, and specifically that upper layer of the skeletal muscle called the superficial fascia. This muscle end up becoming edematous or swollen, and yes, there is necrosis that ends up leading to gangrene. So when you think about necrotizing fasciitis, it is a very aggressive tissue invasion. It does cause necrosis, it causes gangrene, and ultimately, if it's not treated adequately, or if this organism is not treated adequately, you do have amputation of that extremity or that area. Other signs and symptoms you want to look out for is that the area is inflamed. The area has gangrene. It has a rapid increase in size. And yes, you would have to be on contact precautions with a patient that has acute necrotizing fasciitis, because you touching it would then infect you, and then you could have very similar demise on your skin. When we have systemic toxicity, you have to remember that this is starting as a small cut or maybe trauma, or even just an infection. But again, once it spreads, you do have to where it will start getting into the circulatory system. So you can see the systemic toxicity. You'll start seeing fevers due to the organism. You'll see tachycardia, hypotension. This sounds a lot like shock, which is very true. Ultimately, with all of our shocks, you can get organ dysfunction and organ failure. skin treatment, antimicrobial therapy. You want to have aggressive fluid replacement because you want to help flush that organism out. You may have to cut the tissue that's infected off of the individual, and they may even put you in a hyperbaric chamber so it doesn't spread. Um, Ultimately, if we're not able to treat it appropriately, that individual will be subjected to amputation in those extremities. Next, we have leprosy, and this is also known as Hansen's disease. This is an infectious disease, chronic in nature, but it's mostly caused by Mycobacterium leprae, so that's very easy to associate leprosy, but it is a bacteria. Of course, it does affect the skin, but we're not really sure why it develops. It is thought to be spread by respiratory droplets, but otherwise we know it as an idiopathic etiology. As far as signs and symptoms, you have distinct borders. You do have loss of sensation in the areas that are affected, and most times you can treat this with antibiotics because it's caused by Mycobacterium leprae. So you want to encourage use of the antibiotics. The ones specifically are rifampicin. You may recognize that it's a part of the same family as rifampin. You have minocycline or minosin and oxytocin, which is floxin. You have rehabilitation. Once those nerve endings are damaged, of course, you lose that feeling of sensation, so they would have to be rehabilitated with physical therapy. So the last few diseases we talked about were bacterial infections. We're moving into viral skin infections. One of the most notable viral infections is herpes simplex. We do have two different types. Type 1 is the one that we know as cold sores or fever blisters, whereas type 2, this is where we have herpes zoster, genital herpes. So make sure you do know the differences between type 1 and type 2 because they are different due to where they occur. Causative organism, of course, is the herpes simplex virus. Normally it does latent or lay dormant in the nerve ganglia, but it can be triggered. So you'll see this remission versus exacerbation depending on the environmental circumstances with herpes simplex. So you do have triggers from stress, triggers from cold and or sun exposure. But the reason why it spread is due to contact with fluid from the open lesions. So some people will say, oh, they have active herpes simplex. That means that the lesions are open and they actively have fluid coming out of them. But there are times where this fluid does dry up and the lesions are not active. Therefore, it won't be spread at those times. As far as complications, you want to look at the keratitis of the eye. So you can have infection that gets inside of the eye, as well as herpetic whitlow, which is the infection of the fingers. As far as your signs and symptoms, you have sensation of tingling or burning along the nerve and at the site on the lips, particularly with cold sores, or even if it's genital herpes, it would be the same sensation. It's very pruritic in nature when it comes to type 2. It doesn't feel good. As far as treatment, you'll have to use antiviral medications such as acyclovir or valacyclovir, denavir. All of those would be antiviral type medications. Next, we have warts. These are also known as verrucae, and they're contagious and painful. And when we talk about a wart, it's normally a collection of skin, and normally there are vessels that were supplying it blood flow, but those vessels would essentially be cut off, and you would see those vessels that were feeding it be little black dots on the inside of the wart. Causative organism is human papilloma virus, and they have multiple types. Types 1 through 4 is normally what you'll see on feet versus where you have genital warts, and those are types 6 through 11. You do have different types and different sizes of these warts, but the signs and symptoms are the same. They are painful. They can appear anywhere on the body. Most times they have a really rough or grainy textures. And again, what's notable about them is that they have small black dots from the clotted blood vessels that was once feeding them blood flow. Normally we'll use salicylic acid, but you may have to use a combination therapy like freezing the wart, or they may even have to laser the wart as well. So these are sometimes spread through contact. Sometimes you walking around on pavement or even grass can cause you to get them. It can be caused by several different things. But again, once you have them, it is a combined therapy that will help get rid of them ultimately. The next one we'll talk about is fungal skin infections. We'll start with tinea, and what I want to mention about tinea is that they have multiple variants of this. So you have ringworm, um, you have athlete's feet, you even have nail infections. There's multiple types of tinea, but either way, regardless of where it appears or what type it is still considered a fungal infection. So the first one we'll talk about is tinea capitis, and this is where you have a fungal scalp infection, and the organism that's at play here is Trichophyton tonsurans, and it's most common in children of school age. When you have your signs and symptoms, normally there's a circular bald patch, erythema, and when you treat it, it should be a antifungal medication. So you do have orals that would be able to treat the scalp infection. The next one we are most familiar with, the ringworm. And this is the infection of non-hairy parts of the body, so you can get it on your back, on your neck, all kinds of areas, even the neck. So as far as your symptoms, you do have a round lesion with a clear center, and it's very itchy. Normally to treat this one, we'll use a topical antifungal medication such as ketoconazole or tall naphthalate. You have tinea pedis, or athlete's feet. This one's particularly contagious because you can catch this from showers or showering facilities with others. There is an infection on the feet, particularly in between the toes. The organism at play is Trichophyton megatrophites or Trichophyton rubrum. So these are two different types of fungi. But again, it's that species Trichophyton that we're looking at. It's associated with swimming pools. You can get this in gymnasiums. And this is really just an overgrowth of your normal flora that becomes opportunistic. And as we've talked about with opportunistic infections, what would not normally harm you or infect you, once given the right environment and the right conditions, they do proliferate and spread. Symptoms, you'll have inflamed toes, they are itchy, and you may even experience a foul odor. Treatment again would be a topical antifungal medication. The last but not least, we'll talk about the nail infection. This is called tinea unguium, and this is where you have your nails that turn white then brown, and sometimes they'll be thicker and then eventually they crack and spread to other nails. Not necessarily an odor associated with this, but once those nails start cracking, it does run the risk of you getting another infection because your nails are not intact. Treatment, again, antifungal creams, and they will normally treat these tinea infections through the duration, and you have to make sure that you take the course as prescribed. Oftentimes people will start getting decreased symptoms and then they'll stop taking the medication. You do have to take the full course in order for this to be effective. So this is an interesting one to talk about. This is called scabies, and this is where you have a mite, an actual organism that's burrowing into the skin and causing different skin symptoms such as itching, inflammation, swelling, and even redness. But again, these organisms cause severe itching on the client. You do have burrows that you see on the skin, and most times they are light brown lines and they go into a certain direction. That's how you know that there's an organism burrowing into the skin. Common sites of infection would be the wrists, the fingers, elbows, and even the waistline. Causative organism would be the mite called Sarcoptes scabi. So that one's really easy to associate because it looks like the word scabies. Normally it's the females that burrows into the epidermis and they lay eggs. Once those eggs have been fertilized by the male does die, and then the eggs, they end up turning into larvae, and then they go to the skin surface by burrowing further, and then they try to find nutrients. So it's an endless cycle. You do have males and females that would do this, but again, the males do die after they fertilize eggs. This is spread by close contact. You do have to be careful in the clinical environment because this is a very real thing that we get, especially if there are individuals that may have been homeless or individuals that did not have really good living conditions to begin with. We oftentimes see scabies pop up in those patient populations. As far as treatment, you want to use topical Lindane, and normally this is used for a few weeks until they are sure that the mites have been fully destroyed. And yes, if you don't get rid of all of them, the cycle can start back over again. This can happen over several weeks before you can really get rid of the infection. Pediculosis, you may recognize this organism because it's also known as lice. There are multiple variants of this. You have body louse, pubic louse, head louse, all kinds of louse. The plural form of lice is louse, by the way. So this one functions very much like what we talked about with scabies. You do have a female that lays eggs, but in particular, if you're talking about head lice, you're talking about eggs being laid near the hair shafts, and after hatching, the new lice, they will bite humans and suck the blood. So where scabies, they burrow and cause itching, the sucking of the blood in the head is what causes the itching and the macule formation, excoriation is very, very uncomfortable. As far as treatment, you do have permethrin, malthion, and pyrethrin. Normally, you do have to comb through with a fine-tooth comb to get rid of the nits. And also, if you do have a infection with louse, you do want to make sure that you wash all the clothing and the linen surrounding areas, so that way, once the infection has gone from the head, you don't run the risk of getting reinfected. Next, we'll talk about skin tumors. When we talk about skin tumors, these are lesions that are benign, and most times these are associated with old age or skin damage. Most areas that are affected are the trunk of the body and even the face. You do have different types of keratoses, though. You do have seborrheic keratoses, where you have the increase or the proliferation of basal cells that lead to elevations in the skin that may be rough, dark, or they could be smooth. It just kind of depends on its transition. Whereas you have actinic keratoses, and this is where you have ultraviolet radiation that causes these lesions. Normally you see a pigmented scaly patch when it comes to these types of keratoses. So as far as prevention, you want to prevent yourself from being exposed to ultraviolet light, sun exposure during the midday and even in the early afternoon. You want to cover up your body with shade. Make sure you have clothing and hats that would help shield you from the sunlight. Also encourage the use of sunscreen and sunblock. You want to use minimum factor 15 to help protect from your A and B ultraviolet rays, and also protect infants and children from sun exposure and sun damage. The next one we'll talk about is squamous cell carcinoma, and this is a malignant tumor. Normally, once you get diagnosed, it's very easy to find. It's normally a good prognosis when you discover it early enough. We see a trend with smokers having a high incidence of squamous cell carcinoma in the lower lips, which is due to the carcinogens in cigarettes. Sometimes exposure to the sun can cause these malignancies. Scar tissue can also be a source of a carcinoma, and the reason why is because you have malfunctions or malformations in these cells, especially if it's due to sun damage. So while you can have benign um, issues with or benign tumors with your skin, it's also important to know that benign doesn't mean that it'll stay benign forever. In fact, you do see some cases where it does turn into a carcinoma, particularly with squamous cells. You do have the development of scaly and elevated reddish lesions. You do have irregular borders. You may even have some ulcerations in those lesions, and it is a slow growth. It does not metastasize though. So just because it's malignant doesn't always mean metastasize. And when we talk about metastasize, that means that you have these issues that spread to different organs. Normally it's pretty localized. As far as treatment, you want to do surgery, radiation therapy, and they also have various topical medications for squamous cell carcinoma. Next, we have malignant melanoma, and this is a very serious skin cancer that develops from melanocytes. And normally, this one has a poor prognosis, whereas squamous cell carcinoma, although it's malignant, it normally has a good prognosis. Malignant melanoma normally does not have a good prognosis. Normally, you have these tumors that develop on the chest, most times in the back of men. Sometimes you have these develop on the legs in women, but you can see it in other face areas such as the face or the neck. Because these are malignant melanomas, they are quickly growing. They do go down into tissues, and then that's where you start seeing metastasize. So again, where last slide you do have malignancy, but no metastasizing. This one, you have malignancy and it metastasizes. And again, it does lead to a poor prognosis. You do have moles that develop with irregular borders. Some of them are brown, some of them are black. You do have others that can be pink, white, or tan with an irregular border. The thing to remember about screening for all cancers, particularly in the skin, is the ABCD method. You have the area, the border, the color, and the diameter to review. So make sure you understand that concept when it relates to your malignancies. As far as treatment, you want to excise or remove the area of the skin that is malignant, and also especially with the high risk of metastasizing, you want to encourage radiation and chemotherapy in these individuals. Last but not least, we will talk about Kaposi sarcoma. And so we normally see this skin condition with individuals with HIV, but you can also find them in men that originate from Eastern Europe or the Mediterranean, or even younger individuals in Africa. You have immunosuppression, and the herpes virus can cause this. Also, again, when you have immunosuppression with HIV, this makes you develop this condition even more. You do have malignant cells that arise in the endothelium and in small blood vessels. It does present itself as non-pruritic lesions, so it does not itch. They're not painful, but you do see these irregularly shaped nodules on the body. They could be dark, they could be brown, they could be purple. And again, it's because these individuals are immunocompromised. As far as the lesions developing, they are rapid in development. But sometimes if you are immunocompromised, we do see some presentation of painful lesions, but again, that's a very progressed state of HIV. As far as treatment, they may have biologic therapy, which means that they use biologic type medications to help treat this. Surgery, chemotherapy, and radiation would also be involved. But again, this complicates things with the individual with HIV because they are already immunocompromised. Thank you very much for listening to this lecture. I know it was a long one, but if you have any questions about any of the disease processes here, please reach out to me and I'll be more than happy to answer your questions. Thank you.